fluid, electrolyte, and acid-base balance. Fluid surrounds all the cells in the body and is also inside cells. Body fluids contain electrolytes, such as sodium and potassium. They also have a certain degree of acidity. Fluid, electrolyte, and acid-base balances within the body maintain the health and function of all body systems. In this chapter, you will learn how the body normally maintains fluid, electrolyte, and acid-base balance. The characteristics of body fluids influence body system function because of their effects on cell function. These characteristics include the fluid amount called volume, concentration known as osmolality, composition such as with electrolyte concentration, and degree of acidity, known as pH. All of these characteristics have regulatory mechanisms that help keep them in balance for normal function. You also will learn how imbalances develop, how various fluid, electrolyte, and acid-base imbalances affect patients, and ways to help patients maintain or restore balance safely. Fluid balance, shown as Figure 42-2, effects of isotonic, hypotonic, and hypertonic solutions. Please review Figure 42-1, body fluid compartments, as a supplement to this PowerPoint. Fluid homeostasis is the dynamic interplay of three processes: fluid intake and absorption, fluid distribution, and fluid output. To maintain fluid balance, fluid intake must equal fluid output. Because some of the normal daily fluid output, such as urine and sweat, is a hypotonic salt solution, people must have an equivalent fluid intake of hypotonic sodium-containing fluid, or water plus foods with some salt. To maintain fluid balance, fluid intake occurs orally through drinking, but also through eating because most foods contain some water. Food metabolism creates additional water. Average fluid intake from these routes for healthy adults is about 2,300 milliliters, although this amount can vary widely depending on exercise habits, preferences, and the environment. Other routes of fluid intake include intravenous, rectal such as with an enema, and irrigation of body cavities that can absorb fluid. The term fluid distribution means the movement of fluid among its various compartments. Fluid distribution between the extracellular and intracellular compartments occurs by osmosis. Fluid distribution between the vascular and interstitial portions of the extracellular fluid, or ECF, occurs by filtration, shown as Figure 42-3. Osmosis moves water through semipermeable membrane. Please review Table 42-1, Laboratory Normal Values for Adults, Table 42-2, Healthy Adult Average Fluid Intake and Output, and Figure 42-4, Capillary filtration moves fluid between vascular and interstitial compartments, as a supplement to this PowerPoint. Thirst, the conscious desire for water, is an important regulator of fluid intake when plasma osmolality increases, known as osmoreceptor-mediated thirst, or the blood volume decreases, such as with baroreceptor-mediated thirst and angiotensin II and III-mediated thirst. The thirst control mechanism is located within the hypothalamus in the brain. Osmoreceptors continually monitor plasma osmolality. When it increases, they cause thirst by stimulating neurons in the hypothalamus, shown as Figure 42-5, stimuli affecting thirst mechanism. Case study: Robert is a junior nursing student assigned to Mrs. Reynolds. He has cared for other patients with gastrointestinal problems but never one with fluid and electrolyte problems. Robert plans his care by reviewing Mrs. Reynolds' chart and her healthcare provider's orders. The patient's history reveals that she is at risk for a fluid and electrolyte imbalance from a gastrointestinal disturbance and continued use of a diuretic. Fluid output normally occurs through 4 organs: the skin, lungs, GI tract, and kidneys. The GI tract plays a vital role in fluid balance. Approximately 3 to 6 liters of fluid moves into the GI tract daily, and then returns again to the ECF. The average adult normally excretes only 100 milliliters of fluid each day through feces. However, diarrhea causes a large fluid output from the GI tract. The kidneys are the major regulator of fluid output because they respond to hormones that influence urine production. When healthy adults drink more water, they increase urine production to maintain fluid balance. If they drink less water, sweat a lot, or lose fluid by vomiting, their urine volume decreases to maintain fluid balance. These adjustments primarily are caused by the actions of antidiuretic hormone, the renin-angiotensin-aldosterone system known, and atrial natriuretic peptides. Antidiuretic hormones regulate the osmolality of the body fluids by influencing how much water is excreted in urine. It is synthesized by neurons in the hypothalamus that release it from the posterior pituitary gland. ADH circulates in the blood to the kidneys, where it acts on the collecting ducts. People normally have some antidiuretic hormone released to maintain fluid balance. More antidiuretic hormone is released if body fluids become more concentrated. Factors that increase these levels include severely decreased blood volume such as with dehydration and hemorrhage, pain, stressors, and some medications. The renin-angiotensin-aldosterone system regulates ECF volume by influencing how much sodium and water are excreted in urine. It also contributes to regulation of blood pressure. Aldosterone circulates to the kidneys, where it causes reabsorption of sodium and water in isotonic proportion in the distal renal tubules. Removing sodium and water from the renal tubules and returning it to the blood increases the volume of the ECF. To maintain fluid balance, normally some action of the renin-angiotensin-aldosterone system occurs. Atrial natriuretic peptides also regulate extracellular volume by influencing how much sodium and water are excreted in urine. Cells in the atria of the heart release atrial natriuretic peptides when they are stretched, especially when there is an increase in extracellular volume. Atrial natriuretic peptide is a weak hormone that inhibits the antidiuretic hormone by increasing the loss of sodium and water in the urine. Thus, atrial natriuretic peptide opposes the effect of aldosterone, shown as Figure 42-6, major hormones that influence renal fluid excretion. Shown on this slide are the summarized components of fluid balance. Time for a quick quiz. Fluid output normally occurs through all of the following except A. Lungs, B. Gastrointestinal tract, C. Kidneys, or D. Mouth. The answer is D. Mouth. Fluid output normally occurs through the lungs, kidneys, gastrointestinal tract, and skin. Fluid imbalances, if disease processes, medications, or other factors disrupt fluid intake or output, imbalances sometimes occur. For example, with diarrhea, fluid output is increased, and a fluid imbalance, such as dehydration, would occur if fluid intake does not increase appropriately. Two major types of fluid imbalances are known: volume imbalances and osmolality imbalances. Volume imbalances are disturbances of the amount of fluid in the extracellular compartment. Osmolality imbalances are disturbances of the concentration of body fluids. Volume and osmolality imbalances may occur separately or in combination. With an extracellular fluid volume imbalance, too little, known as deficit, or too much, known as excess, isotonic fluid is present. Extracellular volume deficit and excess are abnormal volumes of isotonic fluid, manifested as sudden changes in body weight, and changes in markers of vascular and interstitial volume. Extracellular volume deficit is present when isotonic fluid is insufficient in the extracellular compartment. Remember that a lot of sodium is found in normal ECF. With extracellular volume deficit, output of isotonic fluid exceeds intake of sodium-containing fluid. Because ECF is both vascular and interstitial, signs and symptoms arise from lack of volume in both of these compartments. Extracellular volume excess occurs when too much isotonic fluid is found in the extracellular compartment. Intake of sodium-containing isotonic fluid has exceeded fluid output. For example, when you eat more salty foods than usual and drink water, you may notice that your ankles swell or rings on your fingers feel tight, and you gain 2 pounds or more overnight. These are manifestations of mild extracellular volume excess. In an osmolality imbalance, body fluids become hypertonic or hypotonic, and this causes osmotic shifts of water across cell membranes. Osmolality imbalances are called hypernatremia and hyponatremia. Hypernatremia, also called water deficit, is a hypertonic condition. One of two general causes make body fluids too concentrated: 1. Loss of relatively more water than salt, or 2. Gain of relatively more salt than water. When the interstitial fluid becomes hypertonic, water leaves cells by osmosis, and they shrivel. Signs and symptoms of hypernatremia are those of cerebral dysfunction, which arise when brain cells shrivel. Hyponatremia, also called water excess or water intoxication, is a hypotonic condition. It arises from gain of relatively more water than salt or loss of relatively more salt than water. The excessively dilute condition of interstitial fluid causes water to enter cells by osmosis, causing the cells to swell. Signs and symptoms of cerebral dysfunction occur when brain cells swell. Extracellular volume deficit and hypernatremia often occur at the same time. This combination is called clinical dehydration. The ECV is too low, and the body fluids are too concentrated. Clinical dehydration is common with gastroenteritis, or other causes of severe vomiting and diarrhea, and when people are not able to replace their fluid output with enough intake of dilute sodium-containing fluids. Signs and symptoms of clinical dehydration are those of both extracellular deficit and hypernatremia, shown as Figure 42-7, fluid volume and osmolality imbalances. Please review Table 42-3, fluid imbalances, as a supplement to this PowerPoint. Electrolyte balance. You can best understand electrolyte balance by considering the three processes involved in electrolyte homeostasis. 1. Electrolyte intake and absorption. 2. Electrolyte distribution. And 3. Electrolyte output. Plasma concentrations of potassium, calcium, magnesium, and phosphate are very low compared with their concentrations in cells and bone. Intake comes from foods and beverages. Some substances enhance or hinder electrolyte absorption. Although sodium is an electrolyte, it is not included here because serum sodium imbalances are the osmolality imbalances discussed previously. Electrolyte output occurs through normal excretion in urine, feces, and sweat. Output also occurs through vomiting, drainage tubes, and fistulas. When electrolyte output increases, electrolyte intake must increase to maintain electrolyte balance. Similarly, if electrolyte output decreases, as with oliguria, electrolyte intake must also decrease to maintain balance. Please review Table 42-4, Electrolyte Intake and Absorption, Distribution, and Output, as a supplement to this PowerPoint. Factors such as diarrhea, endocrine disorders, and medications that disrupt electrolyte homeostasis cause electrolyte imbalances. Electrolyte intake greater than electrolyte output, or a shift of electrolytes from cells or bone into the ECF causes plasma electrolyte excess. Electrolyte intake less than electrolyte output or shift of electrolyte from the ECF into cells or bone causes plasma electrolyte deficit. Hypokalemia is abnormally low potassium concentration in the blood. Hypokalemia results from decreased potassium intake and absorption, a shift of potassium from the ECF into cells, and an increased potassium output. Common causes of hypokalemia from increased potassium output include diarrhea, repeated vomiting, and use of potassium-wasting diuretics. People who have these conditions need to increase their potassium intake to reduce their risk of hypokalemia. Hypokalemia causes muscle weakness, which becomes life-threatening if it includes respiratory muscles and potentially life-threatening cardiac dysrhythmias. Hyperkalemia is abnormally high potassium ion concentration in the blood. Its general causes are increased potassium intake and absorption, shift of potassium from cells into the ECF, and decreased potassium output. People who have oliguria are at high risk of hyperkalemia from the resultant decreased potassium output, unless their potassium intake also decreases substantially. Understanding this principle helps you remember to check urine output before you administer intravenous solutions containing potassium. Hyperkalemia can cause muscle weakness, potentially life-threatening cardiac dysrhythmias, and cardiac arrest. Hypocalcemia is abnormally low calcium concentration in the blood. The physiologically active form of calcium in the blood is ionized calcium. Total blood calcium also contains inactive forms that are bound to plasma proteins and small anions such as citrate. Factors that cause too much ionized calcium to shift to bound forms cause symptomatic ionized hypocalcemia. People who have acute pancreatitis frequently develop hypocalcemia because calcium binds to undigested fat in their feces and is excreted. This process decreases absorption of dietary calcium and increases calcium output by preventing resorption of calcium contained in gastrointestinal fluids. Hypocalcemia increases neuromuscular excitability, which is the basis for its signs and symptoms. Hypercalcemia is abnormally high calcium concentration in the blood. Hypercalcemia results from increased calcium intake and absorption, shift of calcium from bones into the ECF, and decreased calcium output. Patients with cancer often develop hypercalcemia because some cancer cells secrete chemicals into the blood that are related to parathyroid hormone. When these chemicals reach the bones, they cause shift of calcium from bones into the ECF. This weakens bones, and the person sometimes develops pathological fractures. Hypercalcemia decreases neuromuscular excitability, the basis for its other signs and symptoms, the most common of which is lethargy. Hypomagnesemia is abnormally low magnesium concentration in the blood. Its general causes include decreased magnesium intake and absorption, shift of plasma magnesium to its inactive bound form, and increased magnesium output. Signs and symptoms are similar to those of hypocalcemia, because hypomagnesemia also increases neuromuscular excitability. Hypermagnesemia is abnormally high magnesium concentration in the blood. End-stage renal disease causes hypermagnesemia unless the person decreases magnesium intake to match the decreased output. Signs and symptoms are caused by decreased neuromuscular excitability, with lethargy and decreased deep tendon reflexes being most common. Please review Table 41-5, Electrolyte Imbalances, as a supplement to this PowerPoint. Case study continued. Mrs. Reynolds' physician has admitted her for observation and has obtained a blood sample for electrolyte levels, complete blood count, and an electrocardiogram. Orders include nothing by mouth, an intravenous infusion of 0.9% saline at 125 ml per hour, intake and output recordings, vital signs every 4 hours, and daily weights. What assessment activities do you anticipate Robert will perform? Assessment activities include 1. Ask Mrs. Reynolds to describe her nausea and what accompanying signs and symptoms she is experiencing. 2. Conduct an examination of gastrointestinal and urinary function. 3. Assess her vital signs. 4. Assess Mrs. Reynolds' skin and mucous membranes for indicators of dehydration. And 5. Evaluation of her laboratory values and electrocardiogram results. Normal acid-base balance is maintained with acid excretion equal to acid production. Acids release hydrogen ions. Bases, known as alkaline substances, take up the hydrogen ions. The more hydrogen ions that are present, the more acidic is the solution. If the pH goes outside the normal range, enzymes within cells do not function properly, hemoglobin does not manage oxygen properly, and serious physiological problems occur, including death. Laboratory tests of a sample of arterial blood called arterial blood gases, or ABGs, are used to monitor a patient's acid-base balance. The pH scale is from 1.0, which is very acid, to 14.0, which is very base, or alkaline. A pH of 7.0 is neutral. Normal arterial blood is 7.35 to 7.45. Please review Table 42-6, Arterial Blood Gas Measures, as a supplement to this PowerPoint. Production. Cellular metabolism constantly creates two types of acids, carbonic acid and metabolic acids. Cells produce carbon dioxide, which acts as an acid in the body by converting it to carbonic acid. Metabolic acids are any acids that are not carbonic acid. They include citric acid, lactic acid, and many others, shown as Figure 42-8. Acid production and excretion. Buffering. If too many free hydrogen ions are present, a buffer takes them up, so they are no longer free. If too few are present, a buffer can release hydrogen ions to prevent an acid-base imbalance. Buffers work rapidly, within seconds. All body fluids contain buffers. The major buffer in ECF is the bicarbonate buffer system, which buffers metabolic acids. It consists of a lot of bicarbonate and a small amount of carbonic acid, normally a 20:1 ratio. Addition of hydrogen ions released by a metabolic acid to a bicarbonate ion makes more carbonic acid. Once that occurs, the hydrogen ion is no longer free and will not decrease the blood pH. If too few hydrogen ions are present, the carbonic acid portion of the buffer pair will release some, increasing the bicarbonate, again returning pH to normal. Other buffers include hemoglobin, protein buffers, and phosphate buffers. Cellular and bone buffers also contribute. Buffers normally keep the blood from becoming too acidic when acids that are produced by cells circulate to the lungs and kidneys for excretion. The body has two acid excretion systems, the lungs and kidneys. The lungs excrete carbonic acid, and the kidneys excrete metabolic acids. When you exhale, you excrete carbonic acid in the form of carbon dioxide and water. If the PaCO2 rises, the chemoreceptors trigger faster and deeper respirations to excrete the excess. If the PaCO2 falls, the chemoreceptors trigger slower and shallower respirations, causing more carbon dioxide to be produced by the cells that remain in the blood. In an effort to make up the deficit, these alterations in respiratory rate and depth maintain the carbonic acid portion of acid-base balance. Sometimes people who have lung disease have difficulty with normal excretion of carbonic acid, which causes it to accumulate and make the blood more acid. The kidneys excrete all acids except carbonic acid. They secrete hydrogen ions into the renal tubular fluid, putting bicarbonate back into the blood at the same time. If too many hydrogen ions are present in the blood, renal cells move more hydrogen ions into the renal tubules for excretion, retaining more bicarbonate in the process. If too few hydrogen ions are present in the blood, renal cells secrete fewer hydrogen ions. Phosphate buffers in the renal tubular fluid keep the urine from becoming too acidic when the kidneys excrete hydrogen ions. If the kidneys need to excrete a lot of hydrogen, renal tubular cells secrete ammonia, which combines with hydrogen ions in the tubules to make ammonium ions. Buffering by phosphate and the creation of ammonium ions turn free hydrogen ions into other molecules in the renal tubular fluid. This process enables metabolic acid excretion in urine without making urine too acidic. People who have kidney disease often have difficulty with normal excretion of metabolic acids. Time for a quick quiz. The body's fluid and electrolyte balance is maintained partially by hormonal regulation. Which of the following statements shows an understanding of this mechanism? A. The pituitary secretes aldosterone. B. The kidneys secrete antidiuretic hormone. C. The adrenal cortex secretes antidiuretic hormone. Or D. The pituitary gland secretes antidiuretic hormone. The answer is D. The pituitary gland secretes the antidiuretic hormone. Acid-base imbalances. People develop acid-base imbalances when their normal homeostatic mechanisms are dysfunctional or overwhelmed. The term acidosis describes a condition that tends to make the blood relatively too acidic. Because our cells produce two types of acid, two different types of acidosis have been identified: respiratory acidosis and metabolic acidosis. The term alkalosis describes a condition that tends to make the blood relatively too basic, or alkaline. Two types of alkalosis are known: respiratory alkalosis and metabolic alkalosis. The body has compensatory mechanisms that limit the extent of pH change with acid-base imbalances. Compensation involves physiological changes that help normalize the pH but do not correct the cause of the problem. If the problem is a respiratory acid-base imbalance, only the lungs can correct the problem, but the kidneys can compensate by changing the amount of metabolic acid in the blood. If the problem is a metabolic acid-base imbalance, only the kidneys can correct the problem, but the lungs can compensate by changing the amount of carbonic acid in the blood. Thus, the kidneys compensate for respiratory acid-base imbalances, and the respiratory system compensates for metabolic acid-base imbalances. These compensatory mechanisms do not correct the problem, but they assist the body to survive by moving the blood pH toward normal. However, if the underlying condition is not corrected, these compensatory mechanisms eventually will fail. Respiratory acidosis arises from alveolar hypoventilation. The lungs are unable to excrete enough carbon dioxide. The PaCO2 rises, creating an excess of carbonic acid in the blood, which decreases pH. The kidneys compensate by increasing excretion of metabolic acids in the urine, which increases blood bicarbonate. This compensatory process is slow, often taking 24 hours to show clinical effect, and 3 to 5 days to reach steady state. Decreased cerebrospinal fluid pH and intracellular pH of brain cells cause decreased levels of consciousness. Respiratory alkalosis arises from alveolar hyperventilation. The lungs excrete too much carbonic acid, or carbon dioxide in water. The PaCO2 then falls, creating a deficit of carbonic acid in the blood, which increases pH. Respiratory alkalosis usually is short-lived, thus the kidneys do not have time to compensate. When the pH of blood, cerebrospinal fluid, and intracellular fluid increases acutely, cell membrane excitability also increases, giving rise to neurological symptoms such as excitement, confusion, and paresthesias. If the pH rises enough, central nervous system depression can occur. Please review Table 42-7, Acid-Base Imbalances, as a supplement to this PowerPoint. Metabolic acidosis occurs from an increase in metabolic acid, or a decrease in base. The kidneys are unable to excrete enough metabolic acids, which accumulate in the blood, or bicarbonate is removed from the body directly, as with diarrhea. In either case, the blood bicarbonate decreases, and the pH falls. With an increase in metabolic acids, blood bicarbonate decreases because it is used to buffering metabolic acids. Similarly, when patients have conditions that cause the removal of bicarbonate, the amount of bicarbonate in the blood decreases. To help identify the specific cause, healthcare providers utilize the anion gap, a reflection of unmeasured anions in plasma. When reviewing laboratory reports, check the reference values from the laboratory that measured the electrolyte concentrations. The abnormally low pH in metabolic acidosis stimulates the chemoreceptors, so the respiratory system compensates for the acidosis by hyperventilation. Compensatory hyperventilation begins in a few minutes and removes carbonic acid from the body. This process does not correct the problem, but it helps limit the pH decrease. Metabolic acidosis also decreases one's level of consciousness. Metabolic alkalosis occurs from a direct increase in base, or a decrease in metabolic acid, which increases blood bicarbonate by releasing it from its buffering function. Common causes include vomiting and gastric suction. The respiratory compensation for metabolic alkalosis is hypoventilation. The decreased rate and depth of respiration allow carbonic acid to increase in the blood, as can be seen by an increased PaCO2. The need for oxygen may limit the degree of respiratory compensation for metabolic alkalosis. Because bicarbonate crosses the blood-brain barrier with difficulty, neurological signs and symptoms are less severe or even absent with metabolic alkalosis. Please review Table 42-8, Anion Gap in Metabolic Acidosis, as a supplement to this PowerPoint. Nurses will apply knowledge about fluid, electrolyte, and acid-base imbalance in many clinical settings. You will also incorporate nursing and collaborative interventions to maintain or restore fluid and electrolyte balance. Apply knowledge of risk factors for fluid imbalances and physiology of normal aging when assessing older adults, knowing that this age group is at high risk for fluid imbalances. Ask questions to elicit risk factors for fluid, electrolyte, and acid-base imbalances. Perform clinical assessments for signs and symptoms of these imbalances. You will learn vital skills and techniques for safe IV therapy, which is a critical area of the nursing knowledge base. Clinical judgments require you to anticipate the information necessary to analyze the data and make decisions regarding patient care. During assessment, consider all elements that build toward making an appropriate nursing diagnosis. Critical analysis of data enables an understanding of how fluid, electrolyte, and acid-base imbalances affect a specific patient and the patient's family. In addition, critical thinking attitudes, such as accountability, discipline, and integrity, assist you in identifying appropriate nursing diagnoses and planning successful interventions. Professional standards such as the Infusion Nurses Society's Standards of Practice provide valuable guidance for appropriate assessment. Nursing process assessment. Using a systematic approach in assessment enables you to help patients safely maintain or restore fluid, electrolyte, and acid-base balances. A patient's fluid, electrolyte, or acid-base imbalance is sometimes so severe that it prevents initial discussion of his or her expressed needs, values, and preferences. However, when a patient is alert enough to discuss care, you need to elicit this information. Focus on the patient's experience with fluid, electrolyte, or acid-base alterations and his or her perceptions of the illness. Ask about the patient's greatest concerns regarding fluid status to build the basis for active partnership in planning, implementing, and evaluating patient-centered care. Clinical assessment begins with a patient history designed to reveal risk factors that cause or contribute to fluid, electrolyte, and acid-base imbalances. Ask specific, focused questions to identify factors that contribute to a patient's potential imbalances. First, assess a patient's age. An infant's proportion of total body water is greater than that of children or adults. Infants and young children have greater water needs and immature kidneys. They are at greater risk for extracellular fluid volume deficit and hypernatremia, because body water loss is proportionately greater per kilogram of weight. Children who are between the ages of 2 to 12 years frequently respond to illnesses with fevers of higher temperatures and longer duration than those of adults. At any age, fever increases the rate of insensible water loss. Adolescents have increased metabolism and increased water production because of their rapid growth changes. Fluctuations in fluid balance are greater in adolescent girls because of hormonal changes associated with the menstrual cycle. Older adults experience a number of age-related changes that potentially affect fluid, electrolyte, and acid-base balances. Hot environments increase fluid output through sweating. Sweat is a hypotonic sodium-containing fluid. Excessive sweating without adequate replacement of salt and water can lead to extracellular volume deficit, hypernatremia, or clinical dehydration. Ask patients about their normal level of physical work and whether they engage in vigorous exercise in hot environments. Also ensure that the patients have fluid replacements containing salt available during exercise and activity. Assess dietary intake of fluids, salt, and foods rich in potassium, calcium, and magnesium. Ask patients if they follow weight loss diets, starvation diets, and those with high fat and no carbohydrate content often lead to metabolic acidosis. In addition, assess the patient's ability to chew and swallow, which, if altered, interferes with adequate intake of electrolyte-rich foods and fluids. Take an alcohol intake history. Chronic alcohol abuse commonly causes hypomagnesemia, in part because it increases renal magnesium excretion. Obtain a complete list of your patient's current medications, including over-the-counter and herbal preparations, to assess the risks for fluid, electrolyte, and acid-base imbalances. Use a drug reference book or a reputable online database to check the potential effects of other medications. Ask specifically about the use of baking soda as an antacid, which can cause extracellular volume excess because of its high sodium content that holds water in the extracellular compartments. For an individual who uses laxatives, ask about the consistency and frequency of stools. Multiple loose stools remove fluid and electrolytes from the body, thus causing numerous imbalances. Please review Table 42-9, Risk Factors for Fluid, Electrolyte, and Acid-Base Imbalances, Box 42-1, Nursing Assessment Questions, and Box 42-3, Commonly Used Medications that Cause Fluid, Electrolyte, and acid-base imbalances, as a supplement to this PowerPoint. Patients who are very young or very old, whose intake and output of fluid and/or electrolytes are not equal, and those who have various chronic diseases or trauma, are at high risk for fluid, electrolyte, and acid-base imbalances. Surgery causes a physiological stress response, which increases with extensive surgery and blood loss. On the 2nd to 5th postoperative days, increased secretion of aldosterone, glucocorticoids, and antidiuretic hormone causes increased extracellular fluid volume, decreased osmolality, and increased potassium excretion. In otherwise healthy patients, these imbalances resolve without difficulty, but patients who have pre-existing illnesses or additional risk factors often need treatment during this time period. Increased output of fluid through the GI tract is a common and important cause of fluid, electrolyte, and acid-base imbalances that requires careful assessment. Acute conditions that place patients at high risk for fluid, electrolyte, and acid-base alterations include respiratory diseases, burns, trauma, GI alterations, and acute oliguric renal disease. Many acute respiratory disorders predispose patients to respiratory acidosis. For example, bacterial pneumonia causes alveoli to fill with exudate that impairs gas exchange, causing the patient to retain carbon dioxide, which leads to increased PaCO2 and respiratory acidosis. Burns place patients at high risk for extracellular fluid deficit from numerous mechanisms, including plasma-to-interstitial fluid shift and increased evaporative and exudate output. The greater the body surface burned, the greater is the fluid loss. Hemorrhage from any type of trauma causes extracellular fluid deficit from blood loss. Some types of trauma create additional risks. For example, crush injuries destroy cellular structure, causing hyperkalemia by massive release of intracellular potassium into the blood. Head injury typically alters antidiuretic hormone secretion. It may cause diabetes insipidus, in which patients excrete large volumes of very dilute urine and develop hypernatremia. In contrast, head injury may cause the syndrome of inappropriate antidiuretic hormone, in which excess secretion of antidiuretic hormone causes hyponatremia by retaining too much water and concentrating the urine. Many chronic diseases create ongoing risks of fluid, electrolyte, and acid-base imbalances. In addition, the treatment regimens for chronic disease often cause imbalances. The specific fluid and electrolyte imbalances that occur with cancer depend on the type and progression of the cancer, and the treatment regimen. Many patients with cancer develop hypercalcemia when their cancer cells secrete chemicals that circulate to bones and cause calcium to enter the blood. Other fluid and electrolyte imbalances occur in cancer because some types of tumors cause metabolic and endocrine abnormalities. In addition, patients with cancer are at risk for fluid and electrolyte imbalances as a result of the side effects of chemotherapy, such as anorexia or diarrhea, response modifiers, or radiation. Patients who have chronic heart failure have diminished cardiac output, which reduces kidney perfusion and activates the renin-angiotensin-aldosterone system. The action of aldosterone on the kidneys causes extracellular fluid volume excess and risk of hypokalemia. Most diuretics used to treat heart failure increase the risk of hypokalemia while reducing the extracellular fluid excess. Dietary sodium restriction is important with heart failure because sodium holds water in the extracellular fluid volume, making it worse. In severe heart failure, restriction of both fluid and sodium is prescribed to decrease the workload of the heart by reducing excess circulating fluid volume. Oliguria occurs when the kidneys have a reduced capacity to make urine. Some conditions, such as acute nephritis, cause a sudden onset of oliguria, whereas other problems, such as chronic kidney disease, lead to chronic oliguria. Oliguric renal disease prevents normal excretion of fluid, electrolytes, and metabolic acids, resulting in extracellular fluid volume excess, hyperkalemia, hypermagnesemia, hyperphosphatemia, and metabolic acidosis. The severity of these imbalances is proportionate to the degree of renal failure. Physical assessment. Data gathered through a focused physical assessment validate and extend the information collected in the patient history. Daily weights are an important indicator of fluid status. Each kilogram of weight gained or lost overnight is equal to 1 liter of fluid retained or lost. These fluid gains or losses indicate changes in the amount of total body fluid, usually extracellular fluid, but do not indicate a shift between body compartments. Patients with heart failure, and those who are at high risk for or who actually have extracellular fluid volume excess should have daily weights. Daily weights are also useful for patients with clinical dehydration, or other causes of all risks for extracellular fluid volume deficit. Weigh the patient at the same time each day, with the same scale after a patient voids. Calibrate the scale each day or routinely. The patient needs to wear the same clothes, or clothes that weigh the same. If using a bed scale, use the same number of sheets on the scale with each weighing. Compare the weight of each day with that of the previous day to determine fluid gains or losses. Look at the weights over several days to recognize trends. Interpretation of daily weights guides medical therapy and nursing care. Teach patients with heart failure to take and record their daily weights at home, and to contact their healthcare provider if their weight increases suddenly by a set amount. The patient's healthcare provider usually sets the parameters for weight gain. Recognizing trends in daily home weights is important. Research shows that patients who are hospitalized for decompensated heart failure often experience steady increases in daily weights during the week before hospitalization. Measuring and recording all liquid intake and output during a 24-hour period is an important aspect of fluid balance assessment. Compare a patient's 24-hour intake with the patient's 24-hour output. The two measures should be approximately equal if the person has normal fluid balance. To interpret situations in which intake and output are substantially different, consider the individual patient. For example, if intake is substantially greater than output, two possibilities exist. The patient may be gaining excessive fluid, or they may be returning to normal fluid status by replacing fluid lost previously from the body. Similarly, if intake is substantially smaller than output, two possibilities are known. 1. The patient may be losing needed fluid from the body and developing extracellular fluid volume deficit and/or hypernatremia, or 2. They may be returning to normal fluid status by excreting excessive fluid gained previously. In most healthcare settings, intake and output measurement is a nursing assessment. Some agencies require a healthcare provider's order for intake and output. If you want to measure intake and output for a patient with compromised fluid status, check your agency policies to determine whether you can institute it or if you need a healthcare provider's order. Fluid intake includes all liquids that a person eats, such as gelatin, ice cream, or soup, what they drink, or receive through nasogastric or jejunostomy feeding tubes. IV fluids and blood components are also sources of intake. Water swallowed while taking pills and liquid medications counts as intake. A patient receiving tube feedings often receives numerous liquid medications, and water is used to flush the tube before and after medications. Over a 24-hour period, these liquids amount to significant intake and always are recorded on the intake and output record. Ask patients who are alert and oriented to assist with measuring their oral intake, and explain to families that they should not drink from the patient's water pitcher or eat from the patient's meal trays. Fluid output includes urine, diarrhea, vomitus, gastric suction, and drainage from post-surgical wounds or other tube status. A patient's urinary output after each voiding. Instruct patients who are alert, oriented, and ambulatory to save their urine in a calibrated insert, which attaches to the rim of the toilet bowl. Teach patients and families the purpose of intake and output measurements. Teach them to notify the nurse or nursing assistive personnel to empty any container with voided fluid, or show them how to measure and empty the container themselves and report the results appropriately. Accurate intake and output facilitates ongoing evaluation of a patient's hydration status. Review the patient's laboratory test results and compare them with normal ranges to obtain further objective data about fluid, electrolyte, and acid-base balances. Serum electrolyte tests usually are performed routinely on any patient entering a hospital to screen for imbalances and serve as a baseline for future comparisons. Please review Table 42-10, Focused Nursing Assessments for Patients with Fluid, Electrolyte, and Acid-Base Imbalances, and Figure 42-9, Critical Thinking Model for Fluid, Electrolyte, and acid-base balances assessment, as a supplement to this PowerPoint. Shown as Figure 42-10, Containers for Measuring Urine Output. Case study continued. Mrs. Reynolds states that she has no appetite, is nauseous, and has been vomiting and has had diarrhea for 7 days. Bowel sounds are hyperactive in all 4 quadrants. The patient has had only 2 loose stools since midnight. She voids with difficulty, with dark yellow urine. Her 24-hour intake was 1,850 milliliters. Her output was 2,200 milliliters, of which urine was only 1,000 milliliters. Temperature 99.6 degrees Fahrenheit, pulse 100 beats per minute, blood pressure 110/60, with no changes when standing. Respirations are 18 breaths per minute and non-labored with bilateral breath sounds clear to auscultation. Robert observes that Mrs. Reynolds' skin is dry, and turgor is decreased. Inspection of mucous membranes reveals that they are dry with thick, clear mucus. The patient's weight of 143 pounds is down 1 pound since admission. Case study continued. Mrs. Reynolds' lab results are as follows: hematocrit 44%, suggesting hypovolemia, potassium 3.6 and sodium 138, both low normal because of prolonged vomiting and diarrhea, and the ECG shows a normal sinus rhythm. Based on the assessment data, what nursing diagnosis should Robert choose for Mrs. Reynolds? When caring for patients with suspected fluid, electrolyte, and acid-base imbalances, it is particularly important to use critical thinking to formulate nursing diagnoses. The assessment data that establish the risk for or the actual presence of a nursing diagnosis in these areas may be subtle, and patterns and trends emerge only when there has been a stool assessment. Multiple body systems often are involved. Careful clustering of defining characteristics leads to a selection of the appropriate diagnoses. In addition to the accurate clustering of assessment data, an important part of formulating nursing diagnoses is identifying the relevant causative or related factor. You will then choose interventions that treat or modify the related factor for the diagnosis to be resolved. Please review Box 42-4, Nursing Diagnostic Process, Deficient Fluid Volume Related to Loss of Gastrointestinal Fluids via Vomiting, as a supplement to this PowerPoint. Case study continued. Robert chooses deficient fluid volume related to excessive diarrhea, vomiting, and use of potassium-wasting diuretic as his nursing diagnosis. The goal he sets are: Mrs. Reynolds' fluid volume will return to normal by time of discharge, and Mrs. Reynolds will achieve normal electrolyte balance by discharge. What are some expected outcomes Robert should establish for these goals? Time for a quick quiz. A senior student nurse delegates the task of intake and output to a new nursing assistant. The student will verify that the nursing assistant understands the task of intake and output when the nursing assistant states: A. I will record the amount of all voided urine. B. I will not count liquid stools as output. C. I will not record a cafe mocha as intake. Or D. I will notate perspiration and record it as a small or large amount. The answer is A. I will record the amount of all voided urine. During the planning process, use critical thinking to synthesize information from multiple resources. Ensure that the patient's plan of care integrates both scientific and nursing knowledge, and all of the information that you collected about the individual patient. If the patient's medical condition is not dealt with in a timely manner, fluid, electrolyte, and acid-base balances will worsen. For example, if a patient experiences vomiting and diarrhea, this needs to be addressed immediately, especially if the patient is young, elderly, or chronically ill. Do not delegate administration of intravenous fluid and hemodynamic assessment to nursing assistive personnel. When the patient is stable, you can delegate daily weights, intake and output, and other appropriate direct physical care to the nursing assistive personnel. Collaborative care may involve other services, including discharge planning, nutritional support, and pharmacy. Ongoing communication and consultation are important because the patient's condition can change quickly. Begin discharge planning early for patients with acute or chronic fluid and electrolyte disturbances by anticipating the needs of the patient and family as they transition to another setting. In the hospital, collaboration with other members of the healthcare team ensures that care will continue in the home or long-term care setting with few disruptions. You ensure that therapeutic regimens established in one setting continue through completion at the next setting. Please review Figure 42-11, Critical Thinking Model for Fluid, Electrolyte, and Acid-Base Balances Planning, and Figure 42-12, Concept Map for Mrs. Beck, as a supplement to this PowerPoint. Case study continued. Some appropriate expected outcomes include: urine output will equal intake of approximately 1,500 milliliters in 2 days, mucous membranes will be moist in 24 hours, skin turgor will return to normal within 24 hours. Daily weights will not vary by more than 2 pounds over the next 2 days. Serum electrolyte and blood counts will be within normal limits within 48 hours, and Mrs. Reynolds will not have any nausea or vomiting in 24 hours. What interventions can you anticipate? Implementation: health promotion activities focus primarily on patient education. Teach patients and caregivers to recognize risk factors for developing imbalances, and to implement appropriate preventive measures. Parents must understand that infants and children need to replace fluids when vomiting or diarrhea occurs. Adults, especially the elderly and the infirm, also need to replace fluids when increased perspiration occurs. Patients with chronic health alterations often are at risk for developing fluid, electrolyte, and acid-base imbalances. They need to understand their own risk factors and the measures to be taken to avoid imbalances. Teach patients with chronic diseases, as well as their family caregivers, the early signs and symptoms of the fluid, electrolyte, and acid-base imbalances for which they are at risk, and what to do if these occur. Acute care nurses administer medications and oral and IV fluids to replace fluid and electrolyte deficits or to maintain normal homeostasis. They also assist with restricting intake as part of therapy for excesses, prevention and treatment of extracellular fluid deficit, hypernatremia, and electrolyte deficits are accomplished with enteral or parenteral administration of appropriate fluid. Enteral nutrition includes oral replacement of fluids and electrolytes. These are appropriate as long as the patient is not so physiologically unstable that oral fluids cannot be replaced rapidly. Oral replacement of fluids is contraindicated when the patient has a mechanical obstruction of the GI tract, is at high risk for aspiration, or has impaired swallowing. Some patients who are unable to tolerate solid foods are still able to ingest fluids. Strategies to encourage fluid intake include offering frequent small sips of fluid, popsicles, and ice chips. Record 1/2 the volume of the ice chips in intake and output measurement. Pay attention to each patient's preferred temperature of oral fluids. Cultural beliefs regarding appropriate fluid temperature may interfere with fluid intake unless the fluid with the preferred temperature is available. When replacing fluids by mouth in a patient with extracellular fluid deficit, choose fluids that contain sodium. Patients who have hyponatremia usually require restricted water intake. Patients who have very severe extracellular fluid excess sometimes have both sodium and fluid restrictions. Fluid restriction often is difficult for patients, particularly if they take medications that dry the oral mucous membranes, or if they are mouth breathers. In acute care settings, fluid restrictions usually allots for half the total oral fluids between 7 a.m. and 3 p.m. This is the period when patients are more active, receive 2 meals, and take most of their oral medications. Offer the remainder of the fluids during the evening and night shifts. Patients on fluid restriction need frequent mouth care to moisten mucous membranes, decrease the chance of mucosal drawing and cracking, and maintain comfort. Fluid and electrolytes may be replaced through infusion of fluids directly into veins rather than via the digestive system. Parenteral replacement includes parenteral nutrition, or intravenous fluid and electrolyte therapy, such as with crystalloids, and blood component administration. IV devices are called peripheral IVs, when the catheter tip lies in a vein in one of the extremities. They are called central venous IVs when the catheter tip lies in the central circulatory system, such as in the vena cava close to the right atrium of the heart. Practice standard body fluid precautions when administering parenteral fluids. Total parenteral nutrition is IV administration of a complex, highly concentrated solution containing the nutrients and electrolytes that is formulated to meet a patient's needs. Depending on their osmolality, parenteral nutrition solutions are administered through a central IV catheter if they are high in osmolality, or peripherally, for lower osmolality. Chapter 45 reviews principles and guidelines for parenteral nutrition administration, which is used when patients are unable to receive enough nutrition orally or through enteral feeding. Shown as Figure 42-13, central venous lines deliver intravenous fluid into superior vena cava near heart. Please review Box 42-5, Cultural Aspects of Care, Fluid Therapy, as a supplement to this PowerPoint. The goal of intravenous fluid administration is to correct or prevent fluid and electrolyte disturbances. IVs allow direct access to the vascular system, permitting continuous infusion of fluids over a period of time. To provide safe and appropriate therapy to patients who require intravenous fluids, you need knowledge of the correct ordered solution, the reason the solution was ordered, the equipment needed, the procedures required to initiate an infusion, how to regulate the infusion rate and maintain the system, how to identify and correct problems, and how to discontinue the infusion. An intravenous solution may be isotonic, hypotonic, or hypertonic. Isotonic solutions have the same effective osmolality as body fluids. Sodium-containing isotonic solutions, such as normal saline, are indicated for extracellular fluid volume replacement to prevent or treat extracellular fluid volume deficit. Hypotonic solutions have an effective osmolality less than body fluids, thus decreasing osmolality by diluting body fluids and moving water into cells. Hypertonic solutions have an effective osmolality greater than body fluids. If they are hypertonic sodium-containing solutions, they increase osmolality rapidly and pull water out of cells, causing them to shrivel. The decision to use a hypotonic or hypertonic solution is based on the patient's specific fluid and electrolyte imbalance. Additives such as potassium chloride are common in intravenous solutions. Administer potassium carefully because hyperkalemia can cause fatal cardiac dysrhythmias. Under no circumstances should it be administered by intravenous push. Verify that a patient has adequate kidney function and urine output before administering an intravenous solution containing potassium. Patients with normal renal function who are receiving nothing by mouth should have potassium added to intravenous solutions. The body cannot conserve potassium, and the kidneys continue to excrete potassium even when the plasma level falls. Without potassium intake, hypokalemia develops quickly. Vascular access devices or catheters are infusion ports designed for repeated access to the vascular system. Peripheral catheters are for short-term use, such as for fluid restoration after surgery and short-term antibiotic administration. Devices for long-term use include central catheters and implanted ports, which empty into a central vein. Remember that the term central applies to the location of the catheter tip, not to the insertion site. Peripherally inserted central catheters, or PIC, enter a peripheral arm vein and extend through the venous system to the superior vena cava, where they terminate. Other central lines enter a central vein such as the subclavian, or jugular vein, or are tunneled through subcutaneous tissue before entering a central vein. Central lines are more effective than peripheral catheters for administering large volumes of fluid, parenteral nutrition, and medications or fluids that irritate veins. Proper care of central line insertion sites is critical for the prevention of catheter-related bloodstream infections. Please review Box 42-6, Evidence-Based Practice, Preventing Central Line-Associated Bloodstream Infections, and Table 42-11, Intravenous Solutions, as a supplement to this PowerPoint. Correct selection and preparation of IV equipment assists in safe and rapid placement of an IV line. Because fluids infuse directly into the bloodstream, sterile technique is necessary. Organize all equipment at the bedside for an efficient insertion. IV equipment include a vascular access devices, tourniquet, clean gloves, dressings, intravenous fluid containers, various types of tubing, and electronic infusion devices, also called infusion pumps. Vascular access devices use short, peripheral IV catheters, and are available in a variety of gauges such as the commonly used 20 and 22 gauges. A larger gauge indicates a smaller diameter catheter. A peripheral vascular access device is called an over-the-needle catheter. It consists of a small plastic tube, or catheter threaded over a sharp stylet. Once you insert the stylet and advance the catheter into the vein, you withdraw the stylet, leaving the catheter in place. These devices have a safety mechanism that covers the sharp stylet when withdrawing it to reduce the risk of a needle stick injury. Needleless systems allow you to make connections without using needles, which reduces needle stick injuries. The main intravenous fluid used in a continuous infusion flows through tubing called the primary line. The primary line connects to the IV catheter. Injectable medications such as antibiotics are usually added to a small IV solution bag and piggybacked as a secondary set into the primary line, or as a primary intermittent infusion to be administered over a 30 to 60 minute period. The type and amount of solution is prescribed by the patient's healthcare provider, and depend on the medication added and the patient's physiological status. If an IV infusion is connected to an infusion pump, then use the tubing designated for that infusion pump. For gravity flow IVs, select tubing as described in the equipment list of Skill 42-1. Add IV extension tubing to increase the length of the primary line, which reduces pulling of the tubing, and increases a patient's mobility in changing position. After you collect the equipment at the patient's bedside, prepare to insert the IV line by assessing the patient for a venipuncture site. The most common IV sites are on the inner arm. As you assess a patient for potential venipuncture sites, consider conditions that exclude certain sites. Venipuncture is contraindicated in a site that has signs of infection, infiltration, or thrombosis. Venipuncture is a technique in which a vein is punctured through the skin by a sharp rigid stylet, as with a metal needle. The stylet is partially covered either with a plastic catheter, or a needle attached to a syringe. After initiating a peripheral IV infusion and checking it for patency, regulate the rate of infusion according to the healthcare provider's orders. For patient safety, avoid uncontrolled flow of intravenous fluid into a patient. You are responsible for calculating the flow rate that delivers the IV fluid in the prescribed time frame. The correct IV infusion rate ensures patient safety by preventing too slow or too rapid administration of IV fluids. Infusion pumps deliver an accurate hourly IV infusion rate. These pumps use positive pressure to deliver a measured amount of fluid during a specified unit of time, for example 125 milliliters per hour. Familiarize yourself with the brand of infusion pump and usage or agency so you are able to set the flow rate accurately. Many infusion pumps have capabilities that allow for single and multiple solution infusions at different rates. Electronic detectors and alarms respond to air in the IV lines, occlusion, completion of infusion, high and low pressure, and low battery power. Regardless of the device in use, monitor the patient regularly to verify correct infusion of IV fluids. Flexion of an extremity, particularly at the wrist or elbow, can decrease IV flow rate by compressing the vein, shown as Figure 42-14, over the needle catheter for venipuncture, and Figure 42-15, common IV sites. Please review Box 42-7, Focus on Older Adults, Protection of Skin and Veins During Intravenous Therapy, as a supplement to this PowerPoint. Maintaining the system involves 1. Keeping the system sterile and intact, 2. Changing IV fluid containers, tubing, and contaminated site dressings, 3. Assisting a patient with self-care activities so as not to disrupt the system, and 4. Monitoring for complications of IV therapy. The frequency and options for maintaining the system are identified in an agency policy. An important component of patient care is maintaining the integrity of an IV line to prevent infection. Inserting an IV line under appropriate aseptic technique reduces the chances of contamination from the patient's skin microflora. After insertion, the conscientious use of infection control principles, including thorough hand hygiene before and after handling any part of the IV system, and maintaining sterility of the system during tubing and fluid container changes, prevents infection. Always maintain the integrity of an IV system. Never disconnect tubing because it becomes tangled, or it might seem more convenient for positioning or moving a patient or applying a gown. If a patient needs more room to maneuver, use aseptic technique to add extension tubing to an IV line. However, keep the use of extension tubing to a minimum because each connection of tubing provides an opportunity for contamination. Never let tubing touch the floor. IV tubing contains needleless injection ports through which syringes or other adapters can be inserted for medication administration. Clean an injection port thoroughly with 2% chlorhexidine, 70% alcohol, or a povidone iodine solution and let it dry before accessing the system. Protective devices designed to prevent movement or accidental dislodgement of a venous access device are called catheter stabilization devices. These devices are available in many hospitals, and nurses decide whether or not to use them when starting an IV line. Accidental dislodgement of an IV is a patient safety issue. Movement of the venous access device in a vein can cause phlebitis and infiltration. Venous access device dislodgement requires using another access device and another infusion site. Infusion Nurses Society standards indicate that use of these stabilization devices is preferred over taping whenever feasible. Shown as Figure 42-16, potential sites for contamination of vascular access device, and Figure 42-17, catheter stabilization device. Patients receiving IV therapy over several days require periodic changes of IV fluid containers. It is important to organize tasks so you can change containers rapidly before a thrombus forms in the catheter. Recommended frequency of IV tubing change depends on whether it is used for continuous or intermittent infusion. To prevent the accidental disruption of an IV system, a patient often needs assistance with hygiene, comfort measures, meals, and ambulation. A potentially dangerous complication of IV therapy is circulatory overload with IV solution, which occurs when a patient receives too rapid administration or an excessive amount of fluids. Assessment findings depend on the type of IV solution that infuses in excess. Infiltration occurs when an IV catheter becomes dislodged, or a vein ruptures and IV fluid inadvertently enters subcutaneous tissue around the venipuncture site. When the IV fluid contains additives that damage tissue, extravasation occurs. Phlebitis, also known as inflammation of a vein, results from chemical, mechanical, or bacterial causes. Risk factors for phlebitis include acidic or hypertonic IV solutions, rapid IV rate, IV drugs such as potassium, vancomycin, and penicillin, IVs inserted in area of flexion, poorly secured catheters, poor hand hygiene, and lack of aseptic technique. The typical signs of inflammation are heat, erythema, and tenderness. These occur along the course of the vein. Phlebitis can be dangerous because blood clots form along the vein and in some cases cause emboli. This may cause permanent damage to veins. Routine changes of peripheral IV catheters to reduce infection are not recommended. Bleeding can occur around the venipuncture site during the infusion, or through the catheter or tubing if these become disconnected inadvertently. Bleeding is more common in patients who receive heparin, or other anticoagulants, or who have a bleeding disorder, such as hemophilia or thrombocytopenia. Discontinue IV access after infusion of the prescribed amount of fluid. When infiltration, phlebitis, or local infection occurs, or if the IV catheter develops a thrombus at its tip. Please review Table 42-12, Complications of Intravenous Therapy with Nursing Interventions, and Table 42-14, Phlebitis Scale, as a supplement to this PowerPoint. Blood transfusion, or blood component therapy, is the intravenous administration of whole blood, or a blood component, such as packed red blood cells, platelets, or plasma. Objectives for administering blood transfusions include 1. Increasing circulating blood volume after surgery, trauma, or hemorrhage. 2. Increasing the number of red blood cells, and maintaining hemoglobin levels in patients with severe anemia. And 3. Providing selected cellular components as replacement therapy such as with clotting factors, platelets, albumin. Caring for patients receiving blood or blood products is a nursing responsibility. You must be thorough in patient assessment, checking the blood product against prescriber's orders. checking blood product against patient identifiers, and monitoring for any adverse reactions. Blood transfusions are never regarded as routine. Overlooking any minor detail can have dangerous and life-threatening events for a patient. Blood transfusions must be matched to each patient to avoid incompatibility. Red blood cells have antigens in their membranes. The plasma contains antibodies against specific red blood cells antigens. If incompatible blood is transfused, the patient's antibodies trigger red blood cell destruction in a potentially dangerous transfusion reaction. The most important grouping for transfusion purposes is the ABO system, which identifies A, B, O, and AB blood types. Determination of blood type is based on the presence or absence of A and B red blood cell antigens. Individuals with type A blood have A antigens on their red blood cells, and anti-B antibodies in their plasma. Individuals with type B blood have B antigens on their red blood cells, and anti-A antibodies in their plasma. A person who has type AB blood has both A and B antigens on their red blood cells, and no antibodies against either antigen in the plasma. A type O individual has neither A nor B antigens on their red blood cells, but has both anti-A and anti-B antibodies in the plasma. People with type O blood are considered universal blood donors because they can donate packed red blood cells and platelets to people with any ABO blood type. People with type AB blood are called universal blood recipients because they can receive packed red blood cells and platelets of any ABO type. Autologous transfusion is the collection and reinfusion of a patient's own blood. Blood for an autologous transfusion most commonly is obtained by preoperative donation up to 6 weeks before a scheduled surgery. A patient can donate several units of blood, depending on the type of surgery and his or her ability to maintain an acceptable hematocrit. Blood for autologous transfusion is also obtained at the time of surgery by normovolemic hemodilution, or through blood salvage, such as during surgery for liver transplantation, trauma, or vascular and orthopedic conditions. After surgery, blood is salvaged via drainage from chest tubes or joint cavities. Autologous transfusions are safer for patients because they decrease the risk of mismatched blood and exposure to blood-borne infectious agents. Transfusion of blood or blood components is a nursing procedure that requires an order from a healthcare provider. Patient safety is a nursing priority, and patient assessment, verification of healthcare provider's order, and verification of correct blood products for the correct patient are imperative. Perform a thorough patient assessment before initiating a transfusion, and monitor carefully during and after the transfusion. Assessment is critical because of the risk of transfusion reactions. Always check agency policy and procedures before initiating any blood therapy. For patient safety, always verify 3 things. 1. That blood components delivered are the ones that were ordered. 2. That blood delivered to the patient is compatible with the blood type listed in the medical record. And 3. That the right patient receives the blood. When administering a transfusion, you need an appropriate size intravenous catheter, and blood administration tubing that has a special inline filter. If a transfusion reaction is anticipated or suspected, obtain vital signs more frequently. The transfusion rate usually is specified in the healthcare provider's orders. When patients have a severe blood loss such as with hemorrhage, they often receive rapid transfusions through a central venous catheter. A blood warming device often is necessary because the tip of the central venous catheter lies in the superior vena cava, above the right atrium. Rapid administration of cold blood can cause cardiac dysrhythmias. Patients who receive large volume transfusion of citrated blood have a high risk of hyperkalemia, hypocalcemia, hypomagnesemia, and metabolic alkalosis, so they need careful monitoring. Transfusion reaction is an immune system reaction to the transfusion that ranges from a mild response to severe anaphylactic shock or acute intravascular hemolysis, both of which can be fatal. When you suspect acute intravascular hemolysis, do the following. 1. Stop the transfusion immediately. 2. Keep the IV line open by replacing the 4 tubing down to the catheter hub with new tubing and running 0.9% sodium chloride. 3. Do not turn off the blood and simply turn on the 0.9% sodium chloride, which is connected to the Y tubing infusion set. This would cause blood remaining in the IV tubing to infuse into the patient. Even a small amount of mismatched blood can cause a major reaction. 4. Immediately notify the healthcare provider or emergency response team. 5. Remain with the patient, observing signs and symptoms and monitoring vital signs as often as every 5 minutes. 6. Prepare to administer emergency drugs such as antihistamines, vasopressors, fluids, and corticosteroids per healthcare provider order or protocol. 7. Prepare to perform cardiopulmonary resuscitation. And 8. Save the blood container, tubing, attached labels, and transfusion record for return to the blood bank. Obtain blood and urine specimens per healthcare provider order or protocol. Another category of adverse transfusion effects is diseases transmitted by blood from infected donors who are asymptomatic. Symptoms of these conditions may arise long after the transfusion. Diseases transmitted through transfusions include hepatitis B and hepatitis C, human immunodeficiency virus infection, acquired immunodeficiency syndrome, and cytomegalovirus infection. In the United States, all units of blood for blood banks undergo screening for HIV, hepatitis B, hepatitis C, syphilis, and West Nile virus. This reduces the risk of acquiring blood-borne infections. Please review Figure 42-18, filling tubing for blood administration, and Table 42-16, Acute Adverse Effects of Transfusion, as a supplement to this PowerPoint. Case study continued. Interventions include: Robert will administer 0.9% normal saline at 125 ml per hour. He will provide Mrs. Reynolds with an additional 480 ml of non-caffeinated oral fluids every 8 hours. He will administer bismuth subsalicylate for diarrhea, as ordered. He will maintain accurate intake and output measurements. He will weigh Mrs. Reynolds daily and monitor trends. He will teach Mrs. Reynolds and her family about specific dietary modifications such as potassium-rich foods. Rationales for these interventions include: replacement of body fluid restores blood volume and normal serum electrolyte levels. An isotonic solution expands the body's intravascular fluid volume without causing a fluid shift from one compartment to another. Bismuth subsalicylate is an antidiarrheal and is given to inhibit GI secretions, stimulate absorption of fluid and electrolytes, inhibit intestinal inflammation, and suppress the growth of Helicobacter pylori. Intake and output documents hydration and fluid balance for directing therapy. Daily weights provide reliable data on fluid balance. Furosemide is a potassium-wasting diuretic. The body does not store potassium, thus requiring dietary supplements rich in potassium. In addition to the administration of prescribed medical therapies, nursing interventions may be performed to preserve or restore electrolyte imbalance. Teach patients the reasons for their therapies and the importance of balancing electrolyte intake and output to prevent imbalances in the future. Nursing interventions to promote acid-base balance support prescribed medical therapies and aim at reversing the existing acid-base imbalance while providing for patient safety. Patients with acid-base imbalances often require repeated ABG analysis. Determination of a patient's acid-base status requires obtaining a sample of arterial blood for laboratory testing. ABG analysis reveals acid-base status and the adequacy of ventilation and oxygenation. A qualified RN or other healthcare provider draws arterial blood from a peripheral artery, usually the radial, or from an existing arterial line. Before an arterial blood draw, perform an Allen test, which assesses arterial circulation in the hand. When performing the Allen test, apply pressure to both the patient's ulnar and radial arteries in the selected hand. The fingers to the hand should be pale and blanched, indicating a lack of arterial blood flow. Release the pressure on the ulnar artery and observe for color to return to the fingers and hand, which indicates that there is adequate circulation to the hand and fingers via the ulnar artery. The Allen test ensures that the patient will have adequate blood flow to the hand if the radial artery is damaged. If color does not return, do not perform radial artery puncture on that arm. After the ABG puncture, apply pressure to the puncture site for at least 5 minutes to reduce the risk of hematoma formation. A longer time is necessary if the patient takes anticoagulant medications. Reassess the radial pulse after removing the pressure. After obtaining the specimen, take care to prevent air from entering the syringe because this alters the blood gas values. To reduce oxygen usage by blood cells, submerge the syringe in crushed ice and transport it immediately to the laboratory. After experiencing acute alterations in fluid, electrolyte, or acid-base balance, patients often require ongoing maintenance to prevent recurrence of health alterations. Older adults require special considerations to prevent complications from developing. IV therapy often continues in the home setting for patients requiring long-term hydration, parenteral nutrition, or long-term medication administration. Initiate patient referral for discharge planning to a social series, counselor, or home care coordinator for assessment of patient and community resources. A home IV therapy nurse works closely with the patient to ensure that a sterile IV system is maintained, and complications can be avoided or recognized promptly. Most patients, who have had electrolyte disorders, or metabolic acid-base imbalances, require ongoing nutritional support. Depending on the type of disorder, fluid or food intake may be encouraged or restricted. Patients or family members who are responsible for meal preparation need to learn to understand nutritional content of foods and read the labels of commercially prepared foods. Numerous medications, over-the-counter drugs, and herbal preparations contain components or create potential side effects that can alter fluid and electrolyte balance. Patients with chronic disease who are receiving multiple medications, and those with renal disorders, are at significant risk for imbalances. Once patients return to a restorative care setting, whether in the home, long-term care, or other setting, drug safety is very important. Patient and family education regarding potential side effects and drug interactions that can alter fluid, electrolyte, or acid-base balance is essential. Review all medications with patients, and encourage them to consult with their local pharmacist, especially if they wish to try a new over-the-counter drug or herbal preparation. Case study continued. Robert's nursing actions include Monitor electrolyte levels and daily weights. Inspect oral mucous membranes. Assess skin turgor, and evaluate intake and output trends during next 48 hours. His findings include serum electrolyte levels for potassium is 4.0, and sodium is 140, mucous membranes remain dry, and skin turgor normal. Mrs. Reynolds' 24-hour intake is 2,800 milliliters, and output is 2,200 milliliter. Of that, 1,800 milliliters is urine. Urine-specific gravity is 1.025, and weight has returned to 143 pounds. Robert is very encouraged by Mrs. Reynolds' progress. Robert discusses sources of potassium in the diet with Mrs. Reynolds and writes this documentation note, denies nausea and reports feeling better. No diarrheal stool since yesterday afternoon around 3 p.m. on inspection. Oral mucosa remains dry, without lesions or inflammation. Skin turgor is normal. Bowel sounds are normal in all 4 quadrants. Abdomen soft to palpation. IV of 0.9% normal. Saline is infusing in left cephalic vein in forearm at 40 milliliters per hour, per MD order. No tenderness or inflammation at IV site. Patient is able to identify 5 food sources for potassium to include in the diet. Patient is resting comfortably, out of bed in a chair, and ate all of breakfast. Will continue to monitor. Evaluation of a patient's clinical status is especially important if acute fluid, electrolyte, and/or acid-base imbalances exist. A patient's condition can change very quickly, and it is important to recognize impending problems by integrating information about his or her presenting risk factors, clinical status, effects of the present treatment regimen, and potential causative agent. For evaluation, you need knowledge of the following. 1. How various pathophysiological conditions affect fluid, electrolyte, and acid-base balance. 2. The effects of medications and fluids. And 3. The patient's presenting clinical status. Compare your current assessment findings with a previous patient assessment. For example, a patient's hypokalemia demonstrates improvement when the serum potassium is increasing toward normal, and the physical signs and symptoms of hypokalemia begin to disappear, or lessen in intensity. Specifically, the patient's heart rhythm becomes more regular, and normal bowel function returns. For patients with less acute alterations, evaluation likely occurs over a longer period of time. In this situation, evaluation may be more focused on behavioral changes, such as the patient's adherence to dietary restrictions and medication schedules. Another important element of evaluation is the family's ability to anticipate alterations and prevent problems from recurring. The patient's level of progress determines whether the plan of care needs to continue or be revised. If outcomes are not achieved, the next questions asked might include the following. What difficulties are you having with measuring your I&O daily and keeping a record? What barriers are you experiencing to obtaining the potassium-rich foods you need? Are you continuing to have frequent loose stools or diarrhea? Or, have you purchased an antacid, or are you still using baking soda as an antacid? Status.